welcome again at Vertex session at Polish Cystic Fibrosis Conference. This time we're connecting with Dr. Krystyna Popłaska, then we will connect with Dr. Justyna Winiarska-Kiefer, who are cooperating with us at the occasion of different workshops at different conferences. So this year, first time we not meeting in person, we're using getting virtual as everything. So thank you very much for joining. And this time we will be learning from CF case reports. Thank you very much. You are with us, and welcome, Dr. Popłaska, and you start cases, and then Dr. Winiarska.
Good afternoon, and thank you for inviting me for this session to speak at this session. And my talk today is a case report, actually. I would like to tell you a short story about Joy. Her name is her character, and the title is How Much Therapy is Too Much. Well, as you can see, there are some photos from 2019 from Poland last year. It was beautiful surroundings, sunshine, and today I'm in Mainz, and I'm talking to you from medical department of Johannes von Gutenberg University, Mainz. Oh, this is actually rainy weather in Mainz. So Joy is 15 years old girl with multiple CF pathogens and a rapid lung function decline. And her case kept our minds very, very busy for the last 4 or 6 years. And the main question was, what does take her breath away? And there's some smaller one as well, which I would like to talk with you, to discuss with you today, which is the best way to treat ABPA, when is the best time to treat Mycobacterium abscessus, how long should we actually treat Mycobacterium abscessus, and how many side effects are we ready to take into account? Which bug should we treat first, Mycobacterium, Aspergillus, or maybe Pseudomonas? And how much therapy is too much for 15 years old? Next slide, please. Well, short history of Joy. She was diagnosed with cystic fibrosis shortly after birth due to Meconium ileus. Her genetic, can you see, and swear chloride levels were 97, so really high. She had a really unremarkable history and healthy development until the age of 7. And maybe this is interesting to mention that we were able to successfully eradicate Pseudomonas aeruginosa at the age of 3, 6, and 11. Next slide, please. Well, in 2011, we found a positive culture for MRSA. She had a little bit cough, dry cough, but we could eradicate this bug after 3 weeks of double antibiotic treatment. And in 2012, she was diagnosed with allergic asthma with allergy against grasses pollen. So we started on inhalation with fluticasone. Well, a really bad year was 2013. As you can see at this graph, FEV1 dropped from 125% to 75%, and her total IgE level increased to 2,400. Well, we diagnosed Joy with allergic bronchopulmonale aspergillosis and started therapy with prednisone and itraconazole. However, due to the relapse of this disease, we were not really able to reduce steroids dose, and Joy wasn't happy about this. She was often unwell, usually with wheezing and dyspnea during exercise, and she was really unhappy about her Cushing signs. So we continue with first questions. What will you suggest as a further treatment for Joy? 1, continue on oral steroids. to assess medication compliance, search for different causes, or change the ongoing ABPA therapy from prednisone to omalizumab. Please take your time. Okay, next slide. Well, we did assess medication compliance. It's always important to do this. We searched for different causes as well, but actually we changed the ongoing ABPA therapy from prednisone to omalizumab. Next slide. And as you can see, we were successful. So FEV1 increased from 78 to 110% of predicted, and Joy started exercising again. Her total IgE dropped under 500, sorry for this, and we were really happy about this development. So in 2015 and 2016, Joy was 12 to 11 years young. She developed a really severe exacerbation with fever and crackles, but not wheezing. Her total IgE level was normal. However, she was on therapy with omalizumab, so you can never say. Bacterial and fungal culture were positive for Pseudomonas, but negative for Aspergillus. And we couldn't find any other pathogens. We decided to treat Joy with intravenous therapy according to guidelines against Pseudomonas for 14 days, but there was only temporary improvement with further drop in FEV1 to 50% of predicted. You can see this development of FEV1 trend. You can see this drop to approximately 50%, which is really a very, very deep one. And as you can see, corresponding total IgE level were actually really normal or not so high. Considering this information, what would you suggest for further treatment? Start oral steroids again, assess medication compliance, search for different causes, or continue with IV treatment against Pseudomonas? Once more, take your time for a while. Well, we did search for different causes. So we decided to perform CT scan and bronchoscopy. As you can see, CT scan revealed some nodules in the upper right lobe and bronchiectasis, predominantly on the right side. And in the bronchoscopy, as you can see, we found some really sticky secretion, but not very green, really white and yellow a little bit. And we could culture Mycobacterium abscessus. So what are actually criteria for diagnosis NTM disease in CF? So the clinical criteria are pulmonary symptoms and the typical findings on high resolution CT scan, and we actually found this. And microbiological criteria, for example, positive culture results from at least one bronchial wash or lavage, and we did this, and we found this as well. So we could diagnose Joy with NTM disease. So next question is, what kind of treatment would you suggest? Well, I was really impressed about this paper. It was published 2016 from Tufts Kvist from Denmark, and he showed that infection with Mycobacterium abscessus can result in really rapid decline in lung function in patients with CF. And that treatment, and yes, please take a look at the right corner of this slide, treatment of Mycobacterium abscessus can improve lung function and can improve decline in lung function over the years. Well, these well-known guidelines from CF Foundation and ECSF recommended 2 phases of treatment: intensive phase with daily macrolide in conjunction with intravenous amikacin and one or more of following: imipenem, cefoxitin, or tigecycline. Well, we should look at susceptibility testing, and as you can see, we've got a problem just now, because this slide shows you that we actually had only 2 antibiotics, linezolid and cefoxitin, but there was no susceptibility to macrolide. As you can see at this typical treatment schedule for CF infection and with Mycobacterium abscessus, there are many blood tests and toxicity monitoring which we should perform. And some of these antibiotics have many side effects, like imipenem, which we started in a case of Joy, but she developed nausea and weight loss and had some healing problems during treatment with amikacin. So I was really happy to find this paper later on about pulmonary Mycobacterium abscessus infection in cystic fibrosis. This is a kind of very practical guideline for children, which was published in Journal of Pediatrics and Child Health in 2019. So as you can see, we decided to look at macrolide resistance, which was the case for Joy. We put her on treatment with amikacin and cefoxitin and gave her linezolid oral as well. We, as you can see at the right side with a green arrow, we did observe a very nice improvement in ABV1 levels, but only for a short period of time. After approximately 6 months, we observe a rapid decline once more, and we didn't really know how to proceed with treatment. So what's your suggestion for this case? How long should we treat after initial good response? Stop treatment after 1 year, consider treatment, consider maybe different treatments, interferon, maybe a possibility, consider other causes for exacerbations, and always again assess compliance. So please take your time. Well, despite many side effects, we decided that 1 year later we had to start an intravenous treatment once more. Why? Well, between 2018 and 2019, we observed a very big drop in lung function, approximately 20%, and we weren't really happy about this. So we decided to take a second look and perform CT scan once more. As you can see, there are many bronchiectasis, not only in the upper right lobe, and some nodules in the upper and lower lobe as well. And during bronchoscopy, we could find a lot of secretion, which was white, sticky, and not really green or greenish. But the really interesting thing about this slide is how often we admitted Joy to hospital. As you can see, in the year 2016 and 2017, she was admitted to our hospital, to our inpatient clinic only 3 times, 4 times 2018 2018, but 8 times in 2019. Well, this is really an impressive one, isn't it? So in spite of continuous intravenous therapy, further decrease in lung function occur. And actually, we were at something like 30% of predicted for FEV1 at the beginning of 2020. As you can see, a very, very rapid decline in lung function, over 50% in this young child. But miracles happen sometimes. As you can see, in 2020, in May, we decided to start IV therapy once more. And then she responded really well to this therapy. We can observe increase, improving in lung function in EBV1 to approximately 66% of predicted, which was a very good result, I think. But then you can see further development, and we were able to reach 84% of predicted in her lung function, which was due to new treatment, which was possible after 3 months of negotiation with health insurance company. In May 2012, the new combination therapy, triplet combination therapy of ivacaftor, tezacaftor, and elazacaftor has not been approved for Germany by her health insurance company, allow us to treat her with this combination and pay for this treatment. So approximately 3 weeks later, we could stop intravenous therapy and Joy could enjoy her holiday without an IV line. Her lung function is still improving. However, sputum samples are still positive for Mycobacterium abscessus. Well, at the end, what could I learn from this case? First of all, pulmonary infection with Mycobacterium abscessus can lead to very, very rapid decline of lung function. Current recommendation maybe underestimate the importance of this pathogen in some patients. Early and consequent treatment must be implemented as soon as possible, I think. And current guidelines are not always suitable for a growing child, adolescent with CF, which may have time for playing, school, and other activities. But the last but not the least, never give up. This picture with rainbow was sent to me from Joy from her holiday place, and she wrote this sentence: never give up, miracles can happen, and I must add it sometimes. Thank you for your attention.
Good morning to my presentation about cystic fibrosis. My name is Justyna Winiarska-Kiefer, and I'm CF doctor from Klinik Löwenstein in Germany, in Baden-Württemberg. I would like to present you a case report. My case is a little bit older, but we can learn a lot of it. Our patient is 33-year-old female CF patient with cystic fibrosis. She is F508 del homozygote. She has a stable lung function with FEV1 values between 43 and 53%, and she has BMI 19.2 kilogram per square meter. She is chronically colonized by Chromobacter xyloxoxidans. In 2016, she developed clinical deterioration with recurrent exacerbation with Achromobacter xyloxoxidans. She has 3 times pneumothorax, so left side pleurectomy had to be done. After stabilization, we transferred the patient to the rehabilitation, but unfortunately during rehabilitation she developed fever, over 40 degrees Celsius, increased sputum production, hemoptysis, and rapid clinical deterioration despite antibiotics. CT thorax scan showed extended bronchiectasis, also isolated consolidations, and mediastinal lymphadenopathy above 15 millimeters. The blood cultures were negative, and the serology for influenza, chlamydia, pneumonia, legionella, pneumophila, HEV, CMV, EBV, HSV1 and 2, VZV, and RSV were negative. There was no indication of autoimmunological disease, so all these autoantibody panels and complement factors were negative. The sputum cultures and also cultures from bronchial lavage showed Achromobacter xylosoccidans and Staphylococcus epidermidis. Despite antibiotics, the patient has fever episodes, very high fever, and rapid clinical deterioration. Laboratory diagnostic showed at first bicytopenia and later pancytopenia, very severe pancytopenia, CRP 12.3, procalcitonin was also elevated, serum iron was very, very low, and very impressive was high serum ferritin, above 2,700 nanogram per milliliter. Transferrin saturation was only 4%, transferrin was in normal standard value, and soluble EL2 receptor was very high, above 8,000 units per milliliter. We consulted a hematologist and oncologist, and he recommended us to perform bone marrow puncture. And bone marrow of this patient showed activated macrophages with phagocytosed bone marrow cells. Hemophagocytosis is detectable in approximately 60% of patients with adult hemophagocytic lymphohistiocytosis. But this criterion is not essential for the diagnosis of AHLA. Adult hemophagocytic lymphohistiocytosis is life-threatening disease. First report was 1928 by Czestovic and Bykova as systemic reticulosis, and this is hyperinflammatory syndrome driven by excessive activation and stimulation of lymphocytes, natural killer T cells, and macrophages with subsequent cytokine storm and organ damage. In childhood, this syndrome is linked to mutations in genes involved in lymphocyte cytotoxicity, and in adult patients is mostly acquired by infections and malignancies. Clinical development is similar to severe infection or sepsis or SIRS. The symptom trias, typical symptom trias, is prolonged fever, hepatosplenomegaly, B or pancytopenia, and other symptoms, eye seizures, meningismus, coma, lymphadenopathy, hepatitis, clotting disorder, skin changes, pulmonary infiltrates, pleural effusion, sometimes ascites or diarrhea. Untreated HLA leads to multiple organ failure. Pediatric patients mostly have genetic defects leading to defects in cytotoxic T cells and or natural killer cells, or defects in inflammation regulation. Adult patients, on the other hand, have a secondary HLA triggered by infections, malignancies, macrophage activation syndrome in autoinflammatory or autoimmune disorders, and sometimes other causes, for example, organ and stem cell transplantation, metabolic, traumatic, iatrogenic causes like immune suppression, vaccination, surgery, hemodialysis, and very rarely also pregnancy. On the right side, you see different infections and causes, for example, viral, bacterial, and fungal and parasites, they can lead to HLA. Which diagnostic criteria does this illness have? They are typical 8 criteria based on pediatric data. They are 2 scores, HLA 2004 diagnostic criteria score and HS score for adult patients. Both are comparable. And most important criteria in pediatrics population is obviously molecular diagnosis consistent with HLA. And in the adult population, 5 of the 8 criteria should be fulfilled in order to make this diagnosis. The most important criteria are fever, splenomegaly, cytopenias, hypertriglyceridemia and other hypofibrinogenemia, hemophagocytosis in a bone marrow with spleen or lymph nodes, no evidence of malignancy, low or natural killer cell activity according to the local laboratory reference, ferritin values above 500 microgram per liter, and soluble EL2 receptor above 2,400 units per milliliter. We have in Germany a national registry, including an associated consulting service. This registry collects cases of adult HLH patients and contributes to a better understanding and improved clinical management of this rare and still often fatal syndrome. This registry is part of a campaign to sensitize clinicians in Germany for potential HLA. We collected since 2010 data of 137 patients at a median age of 50 years. 63.5% were male, and triggering diseases were infections in 44.5% and malignancies in 48%. All patients have elevated ferritin with peak concentrations above 10,000 microgram per liter. 51% of patients died. The worst prognosis have patients with malignancies, with lymphomas, and the best prognosis patients with infections. Platelets level under 20,000 and albumin under 20 gram per liter were associated with poor survival rate. How HLA is managed depends on what triggered the illness. In the case of infections, cortisone and immunoglobulins are given. In the IBV infection, rituximab is indicated. In severe cases, modified HLA-94 protocol is necessary. This is dexamethasone, etoposide, and cyclosporine A. In the case of underlying malignancy, chemotherapy with etoposide and immunoglobulins are indicated. In drug-induced case, tocilizumab and cortisone are the preferred choice. In therapy-resistant cases, allogeneic stem cell transplantation must be done. Our patient received 3 times erythrocyte concentrates and dexamethasone 10 milligram per kilogram during 8 weeks. She received amphomoronal, acyclovir, and cotrim as infection prophylaxis, followed by iron substitution 5 times. Lung function was about 36% and improved to 43% after 1 year. And the body mass index improved from 80.8 to 22.4 kilogram per square meter. In August 2020, we started with ivacaftor, tezacaftor, and elexacaftor therapy, and now the lung function of her is 62% and body mass 24 kilogram per square meter. Hemophagocytic lymphohistiocytosis, HLA, has become more widely recognized in adult patients. Red flags are persisting fever despite broad antibiotic therapy and cytopenia, or a sepsis-like picture without pathogen and only poor response to anti-infective treatments. Highly elevated ferritin concentration are the hallmark. Diversity of clinical pictures in adult HLA often leads to delayed diagnosis and presumably a high number of unreported cases. Physicians should be aware of HLA because early recognition may prevent irreversible organ damage and subsequent death. Subspecialists in different disciplines of internal medicine are challenged by this rare multifaceted syndrome. And the therapy, immunosuppression or chemotherapy, depends on cause and severity, so no one size fits all. Thank you for your attention.